Yep.
So I've got the next talk, which we're going to share a surgical video for Dr Nilofar Noor. She's an ST7 here at Derby and Burton, and she's presenting a case study on managing endometrial cancer in a high-risk surgical case with an absent cervix.
Remember
Hello,
to
everyone.
include.
I'm presenting a case on managing endometrial cancer in a high-risk case with absent cervix. A 72-year-old lady presented with postmenopausal bleeding. She'd previously undergone a cervical amputation and sacrospinous fixation for prolapse. She'd also undergone a laparoscopic cholecystectomy and an anterior abdominal wall hernia repair with a mesh. Speculum examination was difficult owing to vaginal strictures from previous surgery. Pelvic ultrasound showed a thickened endometrium measuring 25 millimeter, and there was no cervix. Hysteroscopy was technically difficult, and it showed a large fluffy mass in the cavity, and biopsy confirmed endometrioid adenocarcinoma grade 1. MRI showed a 2.3 centimeter endometrial tumor. Cervix was not identified, and it classified as FIGO stage 1A. Following an MDT discussion, it was planned for laparoscopic hysterectomy and bilateral salpingo oophorectomy. On the day of the surgery, a vaginal examination confirmed no vaginal disease and an absent cervix with an stenosed internal os. Uterus was mobile. It wasn't possible to insert a Stannard Spachman's, and therefore a swab and a stick was kept in the vagina to help delineate the cervicovaginal junction and help reflect the bladder. A Palmer's entry was used in view of previous surgeries, and laparoscopy showed adhesions between omentum and anterior abdominal wall. Bladder was adherent to the upper vagina. Once ureters were identified in both the pelvic side walls, round ligament was transected on the left side, followed by opening up the anterior leaf of the broad ligament. The UV fold was dissected, and the IP ligament was then transected, followed by opening up the posterior leaf of the broad ligament. Bladder was further reflected, and the uterine vessels were skeletonized, and the uterines were then transected. The same was repeated on the left side. Once both the uterine vessels were transected, bladder was further pushed down. Once adequate cervicovaginal area was identified, colpotomy was then done. A swab and a stick can be noted in the vagina here. There was inadequate space to insert the Stanley-McCartney's tube and to deliver the vaginal through the vagina, the uterus. Therefore, the vault was widened to allow for this to be done safely. The bladder was further reflected to create adequate vaginal length for safe closure of the vault. She had a good postoperative recovery and was discharged the following day on low molecular weight heparin prophylaxis. Histology confirmed grade 1 endometrioid adenocarcinoma of the endometrium. FIGO stage 1A was also confirmed. MDT subsequently was done, and it was planned that no further treatment is needed, and she will be followed up in 6 months' time. The various surgical challenges that we encountered and the preparation that were done accordingly are as follows. In anticipation of adhesions to the anterior abdominal wall in the midline, a Palmer's entry was used for safe entry. Following this, adhesiolysis was done, and secondary ports were then inserted under vision safely, and access to pelvis was obtained. Stenosed internal os and vagina made it impossible for us to use spatmans, and therefore a swab stick was kept in the vagina to help delineate the cervicovaginal junction, push the bladder, and to perform the laparoscopic hysterectomy. Adherent bladder to the vagina was carefully dissected in a stepwise manner. When inadequate space was encountered to deliver the uterus due to stenosed vagina, the vault was further widened for the safe delivery of the specimen. Risk assessment, preparation, and a multidisciplinary approach were key for a safe surgery and a good outcome in this case. Thank you.